well. Stephen, you're the third-year med student. You're in the ER, and you have a young girl who has been in a car crash. She's brought in. You see her eyes are moving. She's talking. And so she was trapped in the car. She has multiple injuries. And what would you like to do to start?
All right, so we'll start with monitor, oxygen, vitals, IV, and then she is responsive. So, ma'am, what brings you in today?
All right.
My belly really hurts.
She said her belly really hurts. It's kind of quiet. But so despite all these horrific injuries, which can be distracting, even though we definitely have to consider the airway on this, they could be distracting injuries. So if she can maintain her airway, what do you think the problem with her is? She's complaining of belly pain. She has a hot belly, it's distended, it's rigid. What do you think's going on with her? She's been in a car crash.
I was gonna say some sort of traumatic abdominal injury.
So she's bleeding in her belly.
Yes.
Okay? So you're right, she has a traumatic injury. So you see the vitals, she's 70 over 40. Generally, with a head injury, they're not going to be hypotensive. So if they're hypotensive, we've got to be looking elsewhere in the body to see what's going on, because that's killing her faster than the head is, right? Yeah. So she's 70 over 40. She has a heart rate of 160. Mm-hmm. But we're talking hypovolemia here, correct, Stephen?
Yes. Mm-hmm.
All right, so if she's hypovolemic, we've had a catecholamine dump to try to help a decompensated blood pressure. Do you really think we want to cardiovert this?
No.
No, you're absolutely right. And if there's nothing else here you learned today, treat the patient and not the monitor. Again, I don't want to make you robots. I want you to think. Okay? But treat the patient and not the monitor. All right, Rick always brings up a really good thought. You know, if you were doing a treadmill, getting your targeted heart rate, you wouldn't cardiovert yourself, and you got to be the one. So just consider that. All right, so you're treating your patient, and gosh dang it, here in VFib Central, guess what happens to your patient, Steve?
Yeah, not good.
I hate it when that happens. So what do you check?
Pulse.
Okay, there is no pulse, and what do you got?
So that would be VFib.
It is VFib. What would you like to do? It happened right in front of you.
So I want to start a defib at 200 joules.
Who is on the monitor?
I am charting to 200 joules. Everybody clear? Shocking?
Good.
All right, and then I want to start CPR 2 minutes.
Gotcha.
What do you want to know?
All right, and then patency of the airway.
So in real life, we would say clear and stuff. That's kind of our canned answer. Patient Stephen, just a little thought-provoking. She's unresponsive with this horrific. Do you think she can maintain her airway?
Probably not.
Probably not. So even before she went unresponsive, we probably would have paralyzed her and intubated her ahead of time. So, okay. But we're definitely going to intubate now. So we do an intubation there real quick. You all see how the tube goes into the cords, just right there. So we intubate her, and 2 minutes is up, Stephen.
All right. Now check a pulse.
No pulse. This is what you got.
All right. I want to do another shock, 200 joules.
You do.
Charging to 200 joules. Everybody clear? Shocking?
Good job. So,
all right.
Go ahead.
Resume CPR.
Shock.
And then 1 milligram epinephrine.
Good job.
1 milligram of epi.
Alrighty, so, and that's given how often?
Every 3 to 5 minutes with no max dose.
Good job. 2 minutes of CPR is up.
Okay, and then let's recheck her pulse.
There is no pulse. That's what you got.
All right, can we deliver another shock, 200 joules?
Can. Kristen?
Everybody clear? Shocking?
Okay.
All right, and then resume CPR.
Good job. And what do you want to give next? Shock.
Right,
Shock.
And then 300 milligrams amiodarone.
Who's on meds?
Oh, that's me. 300 milligrams of amiodarone.
How much more can I give, Stephen?
Another 150.
Good. 2 minutes is up.
Okay, and then recheck pulse.
There is no pulse. That's what you see at the monitor.
All right, so now we have asystole. So I want to do 2 minutes of CPR.
Good. What do you give every 3 to 5 minutes?
1 milligram epinephrine.
Med person. 1 milligram.
1 milligram of epinephrine.
Okay. All right. So, Stephen, another 20 minutes goes by. There is no change in our patient whatsoever. She's probably bled out, and she's still in asystole. We've got to make that tough decision. So, what's it probably time for?
Call time of death.
Yep. So, unfortunately, that's the the hard thing we have to do, but you also have to face reality. For something, guys, one, you can't hurt a dead person, so don't be afraid to try stuff. And two, if it's their time, there's nothing you're going to do that's going to stop it. So just remember that. All right, but not today, Stephen, not you, because you're a third-year med student. You're in the emergency room, and you're not going to put up with the doctor calling this person. So you're not even in a trauma center, but you saw this on TV once. So you grab a scalpel, you push the doctor and the nurse out of the way, and you say, "Stay back," and you're holding the scalpel on him. You turn, and you crack this girl's chest. You grab a rib spreader, you spread her ribs, you clamp a couple of bleeds. You reach in there, you do open heart massage. And 2 minutes is up, Stephen. What do you want to do?
Badass.
I was going to say check a pulse.
You know what? You got a pulse back on her.
Yeah, I did.
Wow, man. How about that?
Only Steve could do that.
Knock the doctor house over here. My God.
What do we call this when we got a pulse back?
This would be Rosk.
Good job. So this patient's probably going to surgery. Sorry, guys. Sorry about that.
Oh, I thought I got theme music for doing that.
You did, man.
I don't think
So, but she's already intubated. So what would you initiate?